Thank you for having me today. I have been managing patients through pharmacogenetics for the past 3 years, and most recently have started a program in a community pharmacy in a rural setting. Warfarin is something that we manage as pharmacists on a daily basis, and as you heard with the previous speaker, many of the published papers, many of the research projects have all been focused on the dose. What's the dose? What do we start the patient on? Whereas in my practice, it's how do I manage this patient? There's so many variables along the way, along a lifetime of warfarin management that can cause issues. So this was a particular patient that got us thinking about the kinetics of warfarin and a daily management. This is a 78-year-old female, typical of what you would see for a lot of warfarin patients. Early onset of AFib in her life, coronary artery disease, severe peripheral artery disease that eventually even led to an amputation, hypertension, high cholesterol. And again, the drug therapy is what you would normally see for a patient. If you notice here, you can see the very minimal dose of warfarin that this patient is normalized on. So when we took a look at her history, we didn't have a lot of information on her initiated warfarin therapy when her AFib was first diagnosed. She was in another state, managed by another cardiologist. But I want to pick up in February of 2012 where warfarin was reinitiated in this patient due to she had a recurrence of AFib after she had had a successful ablation in the early 1990s, and she also had a second episode of DVT. We did an outpatient initiation of warfarin, and this is what ensued afterwards. They were started 5 milligrams daily, normal, and after 4 doses, we had an INR of 6.9. Treatment plan followed normal guidelines to hold the dose until we had a therapeutic INR and restarted a 15% reduction. It took 3 doses held to get to a therapeutic INR, which is a dose or 2 more than it normally would take from that INR to get back to therapeutic. After a reduction of 15%, we decided, well, we'll test a little bit earlier in therapy. 3 doses afterwards, we were back to a 4.7. And this went on and on with this patient. It was a little bit longer than 30 days to get to therapeutic INR. We finally got her normalized on 8.5 milligrams a week and continued at current dosing. She was therapeutic for 45 days, and in May of 2012, the elevated and unpredictable INRs returned. She had many bleeding events. 3 of them resulted in hospital admissions. There were some contributing factors. However, the variability that we were seeing did not match the contributing factors that normally we see in patients' INR variabilities. She did have 2 stop and starts of her warfarin because of procedures. She was restarted in the hospital after procedures at 5 milligrams, which was standard protocol in the hospital, which kind of reinitiated us to where we began with her. They initiated clopidogrel, obviously, after the stent procedure. While clopidogrel is a 2C19 substrate, it does have some 2C9 inhibition. Normally, that's not enough to be clinically significant in a patient, but when you have altered 2C9 genetics in a patient, it will have a clinically significant effect on INR. Antibiotic treatment, she had a couple of minor infections, but it obviously messes with the vitamin K when you're on antibiotic therapy, and you'll see in this patient why it was so significant. Finally, after months of mismanagement with the warfarin, we could not get the insurance to cover alternative therapy for this patient. We did genetic test. She was an intermediate 2C9 metabolizer and had high warfarin sensitivity. So what did that mean to me as a pharmacist? It kind of opened up a world of looking at the kinetics for this patient and managing the warfarin therapy on kinetics versus percentage of dosing. If you look at 2C9 and you look at VCOR, they really operate in affecting the INR completely separate. 2C9 is the metabolism of the drug. So at an intermediate metabolizer, all we're doing is extending the half-life of the drug in that patient. Normally has a 40 to 50-hour half-life, so we're just extending that for our patients who have intermediate or poor metabolism. VCOR sensitivity, however, is going to be affected on how the vitamin K is variable in that patient. So when we looked at her and we looked at the contributing factors of what was taking place with her INR, the picture began to come together, and we were able to put the puzzle pieces together and develop an algorithm of how to treat these patients based on what their VCOR is and what their 2C9 is. So if you look at her, we said 2C9 is intermediate, so we're going to extend her INR evaluation beyond therapeutic monitoring, and you'll see it in these patients. They'll normalize as expected on their dosing, but as the drug compounds with that extended half-life, you'll get a secondary elevation in the INR that you don't expect. So we have extended the half-life, or extended the evaluations in these patients. Then we're going to compensate dose adjustments for any therapy, and it's not only antibiotic therapy, that's a big one, but anything that's going to affect the vitamin K in the gut. Any antibiotic that kills bacteria in the gut, which is the majority of them, is going to affect the vitamin K, because that's where the vitamin K in the gut comes from, is the bacteria that's generating that. So somebody who has very high sensitivity to VCOR, any small variation in the vitamin K in the gut has an enormous effect on an INR, usually 3 times the normal effect of what you will see. So the algorithm that we have developed is pretty much based on that variability. We separate 2C9, we separate VCOR, and based on what the confounding factors are that patient is going to be faced with, what new therapy they're put on, nutritional supplements that they're put on, we're able to use that algorithm and take into account, is this going to be an extension of a half-life of the drug that could cause the INR variability, which the dose adjustments are very different, rather than a VCOR sensitivity, and the timeline is very different. VCOR sensitivities seem to show up very early when you're detecting an INR, within the first 2 to 3 doses, versus an extension of the half-life can come day 7 or 8. What we also finally were successful at doing was getting an EMR, as Warren previously suggested that he uses in his practice. It really has helped a lot of patients to have that baseline INR show up in, or baseline normalized dose show up in their problem list, so that if they are stopped and restarted on therapy after a procedure, then we restart at that INR, or at that dose that we were successful at, versus the normal 5 milligram dose. So as a result for this patient, we had successful warfarin management after the new algorithms were put in place, until she had a decline in health. We eventually did change her to Pradaxa. There were so many nutritional supplements and procedures that were being done that the monitoring that needed to take place was really a patient hardship. But because we had done the genetic test, we did have the documentation of the INR variabilities and the algorithms that were used. We were then able to get the insurance to pay for the Pradaxa, and not only did they agree to pay for it based on the hospital admissions and the cost associated with this, they covered it monthly at no cost to the patient. Thank you very much.